So yes, today I've got given the task of talking about secondary cancers. And I know that sometimes when you start a talk, people start trickling in. So I thought before I jump right into the talk and talk about secondary cancer, it's much easier for me to talk about myself. Now, this is not because I want to promote myself or anything, but I think if you know what your speaker is like and how I do things, then you have a better understanding of why I put the talk in the way that I did. So this photo I took in Hawaii, and I don't know about the projection, but as you can tell, it wasn't one shot. It was taken by 4 different shots and then put together. And I think this is a very good way of illustrating the way that I like to do things when it comes to communicating with the patient. As you know by now, having cancer, having medical problems, going in to see a doctor is such a difficult journey. And we doctors, we hopefully know our stuff, and we will tell you all the things, what the diagnosis is, what to do, the prognosis, and it is quite scary. And sometimes there's just so much information that it's not possible to get it all in one go. So the way that I like to do things is I like to tell my patient that I'm going to draw you the big picture, okay? I'm going to tell you what it is, what we're doing, the risk and everything, okay? It doesn't mean that you're going to get all the risk that you will get from what I've told you when it comes to treatment or the side effects, but it's important to know, okay? So this picture shows that, each time I draw the big picture and each time I focus on little tiny things, and at the end, you get the whole picture of what you're dealing with, okay? And I always like to prepare my patient. Just like this talk, I was in Hawaii, I got my tripod, I carried it for 2 weeks in a row, didn't use it at all until that night, okay? And my wife asked, why do you carry your tripod? I'm like, well, this is the reason, okay? And I think just like communicating with your patient is that you have to give them preparation, you give them time to digest what you're telling them, and so that they can prepare themselves for whatever there is to come. So as you can tell by now, I like to talk, okay? And so a few months ago when people came to me and say, Henry, can you do a talk in this forum? I say, yes, I would. And they say, well, do you want to do a talk on secondary cancer? I say, yes, I would. And then I went home, and then I thought about it, and then I looked at the program, I thought, it is a very difficult topic, okay? Just like this picture, I was driving up this road, the incline was about 30% one way along next to the cliff. Before I went down there, I thought it was a really good idea. And then halfway through, I was like, what have I got myself into? So same for this talk. So actually, the title of this talk took me about 2 weeks to come to, to get to that point. So let's talk about secondary cancer. I think before I started preparing for this talk, I didn't realize how complicated and how confusing it is for patients. Because I went to 4 different websites, all the large international groups, and basically typed in the word secondary cancer. And they give me different definition, okay? Quite often, they will say secondary cancer is when you have one cancer, say lung cancer in the lung, and then you've got the lung cancer gone to, say, your bone or your brain, and that is a secondary cancer. And I was like, well, that's not what I thought, okay? And then you go to all the different Cancer Society websites, not just in New Zealand, they all give a similar picture. And one thing that I'm sure all of you would appreciate by now is that having hematological cancer is very different to having solid organ cancer like lung cancer. It is very hard to find information, and a lot of the time the information seems like it doesn't really apply to you, okay? And so technically, the real meaning of secondary cancer, from my perspective, is when you have one type of cancer, and then later on, you've got another type of cancer that pops up elsewhere that is unrelated to your first cancer, okay? So it's not like, you have lymphoma in one lymph node, and then later on is another lymph node. It's not like that. So here, I made this diagram, and hopefully it will illustrate, clarify some of the terminology. Okay? So on the top, you have these blue cancer cells. Okay? Going down the left, you can see that the blue cancer cell has gone to the liver. Okay? In this situation, most of the time, we will call this either metastases, so it's gone from one place to another, or we will call it a relapse. So you have the cancer, got treated, it came back, still the same color, still the blue cancer cell. Or for some of you who have lymphoma or CLL will appreciate the term transformation. So transforming from a low-grade disease to a high-grade disease. But they're still related. Okay? If you look at their genes, they're still related to each other. Whereas secondary cancer, technically, the true medical term is second primary malignancy, or SPM, is when you have the blue cancer, you treat it, you got rid of it, okay, or put it under control, and then now you've got this yellow-green cancer cells that comes up somewhere else, totally unrelated to your first cancer, okay? So today, I'm going to focus, we're just going to talk about the secondary or second primary malignancy. So, I think the first point to say is the first question is who gets secondary cancer, okay? And what is important to know is that, as you can appreciate, secondary cancer comes after the first one, okay? And so it is mostly documented in cancers that we can cure, or people have a long survival, okay? So some of the examples are Hodgkin lymphoma. Hodgkin lymphoma quite often happens in young people. The treatment is very effective, long-term outcome. It's up to about 90% disease-free survival, and these people live for decades to go. And so because of that time frame between the first cancer and the prolonged survival, these people often been documented to have secondary cancer. Okay? It also happens in patients whom we could actually do something and cure or treat the first cancer. Because if you imagine someone who has a very aggressive disease that we are unable to control from the get-go, well, secondary cancer is less likely to be a problem for them. Okay? So currently, according to the statistics from the United States, approximately 4% of the patients who've got cancer now, actually, it is their second cancer or second primary malignancy. So it is actually common. And we'll come back to this shortly. So why do people get it? Okay, I think this is the most important thing, that why you're all here in this talk today is like, okay, yes, there's the risk, but why? Okay? And the first point that I really, really want to say is that sometimes it is just coincidental. What it means by coincidental, what do I mean by coincidental? If you look at this graph, okay, I promise you I'm not going to put in too many graphs, but here is one from the Statistics New Zealand. It basically looks at the risk of getting cancer as people get older. And unfortunately, time is always linear, which means that every day we are all getting older. And as people get older, the chance of getting cancer, unfortunately, does go up. And so imagine if someone who's in their 30s and in their 40s, they have whatever malignancy, got treated, even if the treatment itself does not increase your risk, just the mere fact that you're getting older means that your risk will gradually increase over time. Okay? Now, in the literature, it's very hard to distinguish whether this is just bad luck, coincidental, or whether it was truly due to the treatment. Yes, we can compare the two groups, say patients who got treated for the whatever cancer and what's their risk of having cancer by the time they turn to 70, compared to someone else who've never been treated with cancer. Yes, I can show you all those numbers, but from a patient's point of view, from your point of view, it really doesn't matter what that number is. Because if it happens, if it's you, then it's you. If it's not you, it's not you. But what I'm trying to say is, yes, although sometimes in the media there's lots of discussion that, could it be the treatment that was giving me cancer? But unfortunately, what we do need to appreciate is that as we live longer and as we become older, the risk does increase. And some of the cancer that's often being associated with old age is, some of you may know, include prostate cancer, and also especially in hematological cancer, chronic lymphocytic leukemia is a relatively common thing. A lot of the time, these patients, especially with CLL, is an incidental finding. They go to the GP, they have a blood test done, they find that their lymphocyte count is high. Yes, by definition, this is a cancer, but no, it's not anything to worry about, okay? So just because you have a second cancer, it doesn't necessarily mean bad news, okay? So, second reason why people can get secondary cancer is because of family history or hereditary predisposition. Now, this is somewhat difficult to explain in hematological cancer because a lot of the study that looks at these families that have recurrent cancer are mainly done in patients who've got breast cancer, ovarian cancer, and bowel cancer. There's not that much study in patients who have hematological cancer. But certainly that we know that patients who come from family who have a family history of cancer, especially, say, CLL or Waldenstrom, and maybe myeloma as well, is that the individual has a slightly higher risk compared to someone else in the community who doesn't have that family history. Now, so as you can imagine, this patient who've got a family history of it, they may have some other cancer before, and now just because of the predisposition, something, that runs in the family, they have a higher risk of developing it, okay? There are some mutations, some very rare mutations where patients have increased risk of having all kinds of hematological conditions. Now, this is a table of all those mutations. This table is very small, and it's small because of one reason. It's because it's not important, okay? It's not important because, for two reasons. Number one, we don't routinely go out and check all these genes for all our patients. Because, number one, the test itself may not be sensitive. Number two, even if we find a mutation, there's very little that we can do in terms of changing the management. And number three, just because you have a negative test, it doesn't mean that you're not at risk. But this is all very academic, but in some ways not very useful. So what is important is that whenever I see my patients, especially for the first time, I ask them, do you have a family history of cancer? And that in itself is more important than whether you have any specific mutation. Because if you have a strong family history, then it will say to me that, hey, you know what, I need to be a bit more careful with you when I follow you up in my clinic, okay? Whether you have mutation or not, it doesn't change anything. And now often when people say, well, maybe we should just do the test, unfortunately, there's no consensus guideline as to how to do this test, okay? And it's very difficult to know how to interpret this test because having a positive test may not mean anything because cancer formation is due to many factors and it's not just a single gene. Okay, so third thing, which is probably, we're getting to the good part of the talk now, okay? So environmental factors is something that we should talk about. It does increase your risk of having cancer in general. So things like, obviously, smoking, okay? So patients who have lung cancer, because they smoke, they also have an increased risk of cancers in the mouth, okay? Having excessive amounts of alcohol also increase your risk of cancer. And obesity, so carrying too much weight. So it has been shown in quite lots of studies that people who carry a bit more weight tends to have an increased risk of certain cancers like colorectal cancer. When it comes to hematology, there is some evidence showing that carrying too much weight can increase your risk of lymphoma, increase your risk of CLL. Whenever I say this to my patient, they will say, well, okay, in that case, maybe I should lose weight. If I lose weight, I will reduce the risk. As of right now, I can't tell you that losing weight will reduce your risk, but losing weight is certainly a good thing for other reasons, which I will come back to shortly. So at this point, I always say to my patients who've just got their, have just gone through their treatment for their cancer, their hematological condition, I say to them, okay, it is important for you to stay healthy, okay? It is important that if you're a smoker, to stop smoking, because you've gone through the journey of fighting the cancer. You don't want to put yourself into a position where you may have to go through it again. So you want to eliminate as much of these risk factors as possible, okay? I'm not asking people not to drink alcohol, obviously, but just be reasonable. Definitely smoking is bad, so stop smoking, okay? In terms of weight loss, I'll come back to that shortly. So the fourth one is treatment-related cancer, and this is probably what all of you are more interested about, and certainly in the media, it is something that people are very interested about, okay? I remember when I was in Toronto, one of the patients I saw, I said, you've got lymphoma, we need to give you chemotherapy, this is the chance of us curing your lymphoma. And then she said to me, but chemo is going to give me cancer. I don't want to have cancer, so I'm not going to have treatment. It took me about another half an hour to slowly persuade her and put everything into perspective. So what we know now about treatment-related cancer is always in hindsight. We are always looking. The problem with statistics is that we are always looking back. All the numbers, if I'm going to tell you, all the numbers are numbers from 20, 30 years, from patients who were treated 20, 30 years ago. And things are different now, and that is very important. Like, these are floppy disks, They store about 1.4 megabytes per disk. My talk itself is 22 megabytes. So that means that if I was doing this talk 20 years ago, I would be carrying about 15 disks as I walk into this room. Now, obviously, things have moved on, and so has the treatment for a lot of disease. And one good example is the treatment for Hodgkin lymphoma. As some of you may know, is that for certain stage of Hodgkin lymphoma, we give chemotherapy and radiation therapy in conjunction with the chemo. And in the past, when we give radiation, we often irradiate the whole area, okay? So what they call, or even right from the beginning, the whole body. But nowadays, when we give radiation to patients, we're only giving it to a small part of the involved area, so what we call involved field radiation. And certainly in some centers, they're moving to what we call involved site radiation. So the amount of radiation that you're getting has moved on, has become much less than what it was 20, 30 years ago. And the reason why I want to mention this is because remember from the very beginning of my talk, I said one of the most well-documented disease that can give you secondary cancer is patients who've got Hodgkin lymphoma, okay? And young female patients who have Hodgkin lymphoma had chemotherapy, they also had radiation therapy, and so they're at an increased risk of breast cancer. And so currently I don't look after patients with Hodgkin lymphoma, but I did when I was in Toronto. And one of the things that we say to patients, yes, in the past, the radiation did increase your risk of having breast cancer quite substantially. But currently, the dose is much smaller, The field is also much smaller. And so the risk is, I'm not saying that it's zero, but it's certainly not going to be as high as it used to be. So I think with the internet today, everyone will go online, will look at all the literature, but just be aware that whenever you look at all these things about secondary malignancy, we are looking at treatment that was 20, 30 years ago. And also, you need to put it into perspective. So if I tell you that I took this picture as I was flying through the Sahara Desert, would you believe me? No? Oh, I thought someone would, okay? Yeah, thank you, yes. But actually, this is just a picture that I took on a beach, but I took out the sky and I just focused on the sand. And it looks like it was in the desert. So same for treatment-related secondary cancer. Yes, we can focus on that risk. But at the same time, we also need to focus on what we are dealing with right in front of us. This cancer, this bad cancer that's right in front of us, that we have to deal with it. Because if we don't deal with what's in front of us, we won't have a chance to even worry about what's going to come next, okay? So it is all about putting into perspective. I still have to tell you about the potential risk. I don't want you to go home or go back to your clinician and say, oh, I had a talk from Henry the other day, and he was telling me about all these risks, so you know what, I'm not going to get any treatment, okay? So please don't do that, because otherwise I don't think I will be able to keep my job, okay, or I will never be invited to speak again. But as I said from the get-go, that I think as a patient, it is your right to know about the risk. And when you know about the risk, then it better prepare you for whatever there is to come. So we use radiation treatment quite frequently, mainly in the setting of lymphoma, as I said. Radiation does increase your risk of cancer, and is often localized effect. So if you get radiation to your chest, then the secondary cancer usually arises within the area where you got irradiated. Okay, so taking that Hodgkin lymphoma as an example, where patients get radiation to their upper chest, and female patients having an increased risk of breast cancer. Quite often, this type of cancer happens about 5 to 10 years down the track. It usually arrives right on the edges of where you irradiate. Okay? And depending on the type of cancer, it is either dose dependent, so the more you have, the more radiation you have, the greater the risk. Or for certain cancer, like in leukemia, it is about the extent of the radiation. Okay? And when it comes to chemotherapy, unfortunately, chemotherapy is still a toxic medication. As a field, we are moving on. We are trying to use less chemotherapy, more of the new drugs that are less toxic, more targeted. But unfortunately, chemotherapy is still a very important backbone of treatment for all kinds of cancer, including hematological malignancy. In terms of medication, some of you will recognize some of these names. So we classify them into different groups. So the first group to always talk about when it comes to secondary cancer is what we call alkylators. Alkylators are like things like cyclophosphamide. You would recognize this name because we use cyclophosphamide quite frequently in treating lymphoma and also myeloma as a first-line treatment. Melphalan, for some of you who've gone through stem cell transplant for myeloma, will remember this name. We use melphalan as a preparation for your stem cell transplant. And clorambucil is a very old chemo drug that we usually leave it as a last line of resort. Okay, it's an oral tablet. These medications are very effective. I mean, patients who have myeloma, who have lymphoma, having cyclophosphamide, melphalan, they have a very high rate of responding. For lymphoma, there's a good chance of cure as well. But unfortunately, the higher the dose that we give, the greater the risk of secondary cancer. Okay? And at this point, it is important to note that as a field, we are trying to reduce the dose of our chemotherapy as time goes on. And one good example is actually lymphoma. In the past, as some of you may know, we give CHOP, C-H-O-P. Back then, we didn't have rituximab. And for CHOP, we used to give 8 cycles. And nowadays, as you know, we don't usually give 8 cycles of chemo. For our CHOP, we do 6. And that is one example of us going, okay, 8 cycles was effective. Can we do 6? Oh, 6 was just as good. Oh, well, they just do 6 instead of 8. So we are trying to cut down, but at the same time, there is so much reduction that we can do before it becomes ineffective. Okay? So when you look at the study, when you look at the data about the risk of secondary cancer with cyclophosphamide, just bear in mind that maybe the dose that I'm getting today is not quite the same as what it was used to be. The second class of medication that can give you secondary cancer is what we call topoisomerase 2 inhibitors. Okay? These are medications such as etoposide. Now, what is important about these two class of medication is that for the first one, the alkylators, the risk is usually a bit later on down the track, okay? About 5 to 10 years. Whereas the other one, the risk of developing cancer is earlier on, about 2 to 5 years. And why is it important to mention this? It's because, as some of you will know, you see us in our clinic, we treated your cancer. After a few years, we say, good, you're doing well, you don't need to see us, you're in remission now, okay, and you can go back to your GP. But before I send my patient out, I always say to them, it's important that you go and see your GP. You may feel perfectly fine, but still, make sure you get a blood test done every 6 to 12 months. Why? Because this risk of having secondary cancer, mainly in terms of myelodysplastic syndrome, does happen later on, or can happen later on, and quite often you can pick it up on a blood test. And so it's important that once you have left us, okay, go out in the community, enjoy life, happy, just make sure you still keep a good relationship with your GP for blood tests. There are other medications, other chemo medications that can increase your risk of secondary cancer. The anthracycline, so for example, doxorubicin, one that we use often in patients with lymphoma. We used to use doxorubicin for myeloma, but we haven't been doing that for the last probably close to about 7 to 10 years now. Okay? And then platinum-based medications, they're usually being used in patients who are not responding to the first-line chemotherapy for lymphoma, and they need to, say, go for a transplant or go for second-line treatment, and that is when platinum-based medication is used. Now, these are all the older generation of chemotherapy, and because we've been using them for a few decades now, we know that there is such a risk. Okay? The risk, how high? Well, it's just like how long is a piece of string. It's really hard to say. Certainly, your risk is higher than someone else who have never had cancer or who have never had treatment. But the absolute risk itself is not that much more than others, okay? One thing that I want to mention is that some of the new medications that are coming through, especially there's a new medication called lenalidomide, which is being used in many settings, and probably one of the biggest area that we would use lenalidomide is in patients with myeloma. It's very effective, but it does increase patients' risk of having secondary cancer. Not quite sure why it does that. Because the old chemo drugs, the reason why it causes secondary cancer is because the medication goes into the body, finds the DNA, binds to the DNA, and damages the DNA. And the theory is that for a cancer cell that already got damaged DNA, having more damage will be bad for the cell, and the cell will die. Whereas for the normal cells, they can take the damage and they can repair the damage. So all chemo drugs damage DNA, okay? And so unfortunately, sometimes the chemo itself can cause too much damage and increase the risk of secondary cancer. Whereas some of the new drugs, so say lenalidomide, it doesn't really go to the DNA. It works in a slightly different manner. It changes the immune system. Not sure why, but it does look like that patients taking lenalidomide long-term does have a slightly increased risk. So once again, I'm not discouraging anyone from having any treatment, but I just think that it's important to go through some of these medications and just to be aware that, you know, I'm at a slightly higher risk, but it's okay as long as I get checked out frequently. So it is scary, but remember things are different now. As I said, say for example, the CHOP chemo, we are giving shorter duration. And just like the dosing for the radiation therapy, we are giving a lower dose. And it is important to put it into perspective. In Toronto, they can give lenalidomide maintenance after someone who has a stem cell transplant for their myeloma. And so as the fellow, you will see the patient 3 months after transplant and say, hey, you've done well with your transplant. We're going to start you on this medication called lenalidomide. It's just an oral tablet that you take daily. And so the first thing you say to them is, well, I had a look, there was this study that shows that patients who took lenalidomide, they live longer. They had a longer period before they get their myeloma back. And the risk at any time, any point of time, is about half of those who are not taking lenalidomide. So you tell that to the patient, they're all very happy, go, yeah, I like it. But then you have to tell them that, well, but at the same time, you do need to understand there's always potential risk. And when it comes to lenalidomide, as I have pointed out before, those patients who had the transplant without lenalidomide, about 4% of them will have secondary cancer later on during the follow-up. During the same period of time, 8% of those patients who have lenalidomide had secondary cancer. So this one patient said to me, so you reduce my risk of relapse by half, but you increase my risk of secondary cancer by twofold. So it's exactly the same. So why do I need to bother taking it? And so at the end, I show them this graph. And what it shows is your risk of having secondary cancer if you're not taking lenalidomide. If you are taking lenalidomide, the risk is double. But if you look at everything all together, if you include the risk of the disease coming back and the risk of the secondary cancer, people who don't take lenalidomide do poorly. So the higher the number, the worse it is. Whereas people who took the lenalidomide yeast, the risk of secondary cancer is increased, but because they get so much more benefit in terms of their myeloma, they do better. And so, once again, it goes back to the question, is that the risk is there, unfortunately, but it is about putting it into perspective. And sometimes I say to my friend, some of them, they're not medically trained. They say, well, Henry, why do you give chemo to people? It's such a nasty drug. And I say to them, well, when I wake up in the morning, I don't go to work and say, let's just see how many patients I can put them onto chemo today, okay? Let's see how much suffering I can do. Okay. My pure intention is to say, well, based on what I know, I think during this treatment, although it's tough, although it does have potential side effects, okay, but hopefully, by doing so, I'm changing you from this line to this line so that you do better. And I can say wholeheartedly that all clinicians, as far as I know, will think the same, okay? We always talk amongst ourselves and go, okay, what are the risks for treatment and what are the benefits of treatment? And before any treatment is decided, usually the benefit has to outweigh the risk. And that goes the same for secondary cancer as well. So, a quick summary. Remember, secondary cancers applies to patients who have done well for their first cancer and live a long time, okay? And secondary cancer can be coincidental. Just as you become older, the risk increases. It could be because of pre-existing family predisposition. It could be due to other things like smoking or alcohol that increase your risk. And so lifestyle changes is important. And although treatment does increase your risk of secondary cancer, and I'm not hiding this at all, it is important to know that sometimes what is important is to deal with what is in front of you and then have to just fight one battle at a time. So, moving forward. See, that's why I find this talk very difficult. All the other talks is about how you can live a full life, be happy, and move forward in the battle against the cancer. And I'm like, you've got secondary cancer. Very depressing. But anyway, my last slide is going to be positive. Okay, so looking forward. So what can you do? This is what I say to all my patients. Always keep an accurate record of your treatment. What do I mean? I mean the types of chemo that you have and the date is important. Because yes, in New Zealand we're great. The clinicians can easily communicate with each other, but some of you may want to travel overseas, may want to go elsewhere for treatment, or may want to live somewhere else. And so it's important that as a clinician we know what you had before. It's not just because of the risk of secondary cancer, but it's also to know that, well, you had this treatment before, okay, these are the potential side effects that we need to watch out for, so we'll keep an eye on you this way. So keep a record of your treatment. So in terms of what I would like my patients to be able to tell me when I ask them what treatment they had, they will say, this is my diagnosis, where was it? So for example, in lymphoma, having a lymph node in the neck and then having radiation there means that, well, we need to worry about or keep an eye out for cancer in the upper chest because that's where you had your radiation. Okay? It will be different if you say you had radiation in your groin. Okay? And other things like how long was the treatment, okay? And just some details. And so now some of you will be looking at me and go, well, but yeah, you're the doctor, you know all this, but for me, how am I going to find out? So normally, whenever we send out a clinic letter, there's a problem list right at the top, okay? The problem list should usually say, this is what you have, this is how you present it, and this is your treatment. So keeping a copy of your clinic letter is important. Now, as time goes on, whenever we dictate clinic letters, sometimes we will go, we don't want to dictate the same problem list again because you're 5-6 years down the track, you're doing well, basically you're just coming in to see me and I say you're doing fine and there's 5 minutes and you really want to go because you're fine. So we don't dictate the full problem list, okay? But so usually the clinic letter straight after the completion of treatment has the most complete problem list. As time goes on, that problem list will become more and more abbreviated. Okay, so if you're going to get a copy of it, okay, assuming that your doctor tends to abbreviate your problem list, get the one straight after the completion of treatment because it will have your diagnosis, your treatment, and most frequently, your treatment response. Okay. The second thing that I say to my patient is turn up to the clinic follow-up. Turn up to your appointment. Not just my appointment, everyone else's. Your GP, your cardiologist, the gastroenterologist. Because if we don't see you, we can't keep an eye on you. But if we do see you, we can keep an eye on you. It doesn't mean that we can pick it up every single time. No one is perfect. But at least it improves your chance. So going to your GP to have regular blood tests, as I say to my patients, at least every 6 to 12 months, depending on your status. And just having regular cancer screening. So some people say, well, I had cancer, do I still need to go for my mammography, or should I still do the colorectal cancer bowel screening program? I say, yes, still go and do it, okay? Internationally, there is some guidelines or some country will say if you have radiation to your upper chest, you should have a mammography once a year and clinical examination twice a year. As far as I know, talking to the oncologist, we don't have this plan in place. It doesn't mean that we are behind and we're not doing what we should, but it illustrates that there is a need to make sure you go and have your cancer screening done and go and make sure you have all your follow-up with your GP. And the third point that I will always say to my patient is stay healthy, okay? You can eat and drink whatever you want, okay, but not excessive, okay? As long as you're happy, that's the main thing. Lose weight if you're overweight, okay? Keep fit. And then you say, well, Henry, you just said about 20 minutes ago that losing weight may not reduce your risk of secondary cancer, so why do I need to do it? Because I can tell you now, in all clinical studies, well, maybe not all, but most clinical studies, one factor that is constantly true is that the better you are, the fitter you are before any treatment, the better your outcome. who cares about whether you're going to get secondary cancer or not? Okay, don't worry about all that. If you're fit, you live a healthy life, you enjoy your life. Okay, God forbid, if you do get secondary cancer or if the cancer does come back, you're in a better shape. You're in a better shape to fight it. Okay, so it's important to stay healthy, keep fit, and be positive.